Good morning. Welcome to Section 100. Everybody's bright and shiny faces this morning starting out. We have a group of occupational medicine physicians who, from Canada to another country, a third world country called Louisiana, and as a result of that, we'll see a quite varied presentation view of occupational environmental medicine. The other thing, I do have to clarify one thing. When we put this together, all the women in occupational medicine that we thought of to present were presenting somewhere else. So we're going to start this year. So next time we will have a woman presenting about occupational environmental medicine. But we'd like to welcome the physicians, physician's assistants, nurses, everyone here today to this session, because that's a reminder for everybody to turn their cell phones to vibrate. Thank you, Pete. So let's really get started. I'm Mark Roberts. We have Bob Bourgeois on this side, and we have Chris Stewart-Patterson on this side, and then Dr. Doug Martin will be in. He's in the House of Delegates right now. And so the lineup will change just a little bit depending on when Dr. Martin gets here. But I'll get it started. So what I'd like to do is really, I've talked about our faculty. I'd like to also thank Michael Levine. I stole a whole bunch of his pictures, and so I should give him credit for that. We're going to talk about the good, the bad, and the ugly, trying to stress the good, obviously. But occupational environmental medicine is a dynamic practice, specialty, and I chose this, good, bad, and the ugly, not thinking about the presenters. So that's one thing that I need to point out. But one of the things is really the fact that the specialty of occupational environmental medicine is not well known. I've been called an occupational therapist. I've been called an industrial hygienist. But today we're really going to focus on what we're doing as occupational medicine physicians. As another disclaimer, I need to point out that I spent 17 years in the State Health Department of Oklahoma. That's where the accent's from, doing rabies, scabies, head lice, and cancer clusters. Then went from there to the Medical College of Wisconsin to teach physicians, some of them in this room, and I'm not sure why they're in this room. They could give this presentation as well as me. Spent a little time as a corporate medical director in a couple of big energy companies, and for the last 10 years have been a consultant in a company looking at rabies, scabies, head lice, and cancer clusters. So I'm circled back again. So anyway, but we'll draw on that. But a number of things that we're going to talk about you're familiar with, or you will be familiar with as you do occupational environmental medicine. The other thing is, another disclaimer, this is about ACOEM, and about ACOEM, what ACOEM can provide to you as a practicing physician, nurse, PA, in the practice of occupational environmental health. There's nothing magic about what we do. It's a subspecialty preventive medicine, but do you know what that really means? Preventive medicine really talks about populations. And that's what we deal with. You're in a private practice, you're in a general medicine clinic, and you see somebody that works at the local plant. You focus on what they're there for. But then think about it in terms of what does that person reflect for the population, the employees at that work site. It's really important to think about it. You know, it's about you see the tree, but think about the forest. It's really, really important that you understand that part of your role is to help improve the health of the individuals at that work site. The other thing is, used to when I would talk about this, talk about regulatory compliance, that was a new term for physicians. Today there's so doggone many regulations that all we're doing is changing the acronyms. You've got regulations. But you can step off in a hole, if you will, not knowing things about ADA and the FMLA. and now the ACA. The other thing is medical legal work. One of the things that in general practice you're going to see medical legal issues, malpractice issues, hopefully not yours, but others. But in the occupational environmental medicine sector, there's a thing about causation, whether it be work comp or it could be toxic tort. So you need to keep that in mind as well. And that's something that again, there is educational offerings at ACOEM concerning that. We're going to talk about what docs do. Here's a list. This is not new to you. You've seen this before. But there's a growing number of things. And we go back to health and wellness now and how that ties back in to population-based medicine. You know, who's doing occupational environmental medicine? More and more primary care docs are getting involved with it. There's fewer and fewer corporate medical directors. There are fewer and fewer company docs. What we're seeing is growing organizations that are providing combination of primary care and occupational environmental medicine. So you may be in a hospital-based program, and the administrator may come in and say, we're going to start an occupational health clinic, and we want you to run it. Second question you should ask after the budget is, am I going to see hospital-based employees? As a corporate medical director, that was one of the things that I used to evaluate how good that clinic was. If that clinic was seeing their own employees, that told me that they understood what was going on in occupational medicine. The trend is that the brunt of occupational environmental medicine is being done by non-boarded occupational physicians. We understand that, and the goal is to educate, not necessarily recruit. There is information in the back about becoming a fellow of the American College of Occupational and Environmental Medicine. There's also other educational opportunities. But the point being, more importantly, to improve the health of employees. And so that's really what we're striving for. You know, there's still coal miners, but the workforce is really, really changing. There's a lot of people that are getting injured. Partly it's not the amputations and that sort of thing as much as the psychological aspects now. The conditions that you're seeing that are work-related, stress-related, for example. How do you define that? How do you determine it? How do you measure it? Those are all things that are on the forefront, and Chris will touch on that just some today. So we're going beyond the care of the individual patient. Yes, treating them for what ails them, but also looking at it in terms of how does this reflect on the workforce from which they came. Talk about causality, workman's compensation, also the toxic torts. I think the other thing to keep in mind and what you'll see in our presentations is about teamwork. It's a different team. Teamwork and member of team was in vogue in the 90s, and then it went away. It truly is a team effort in occupational environmental medicine, and you're going to see that again. Now, one of the things to also consider is the fact, the E in OEM, the environment. The workplace environment, the plant facility affects the community. You may have questions about community health issues as it relates to the plant. That can be a two-edged sword in the fact of you're seeing employees from there, you have a contract with that company, and then one of your patient comes in and says, that company is making me sick. What do you do? How do you handle that? Talked about the team. Quickly, understand that there are individuals that know more about that work site than you do. If you're a hospital-based or clinic-based physician, you're going to need to network with the industrial hygienist, the safety professionals, the nurse, the PA. I learned an awful lot about how to do occupational environmental medicine from the nurses at Miller Brewery and Aldridge Chemical in Milwaukee. So remember, it's a team effort. Now we've got case managers. You've got case managers that work for the company. You've got case managers that work for the insurance company. You know, how do you assess, how do you handle the situation when the case manager comes in with the patient and says, I'm here to observe the interaction. I'm here to talk with you about the individual. How do you handle that? You've got to understand you're dealing with unusual workplace exposures. You won't see this one very often, but it brings home the point that know the workplace. One of the disadvantages that you have as being a clinic physician away from the plant is to not know what the plant is, how it's being operated. I had a guy that the doc called me and said, you know, you've got to take Eddie off the line. He told me he shoveled, I don't know, 50,000 bent cans. We didn't produce that many cans that day, so he couldn't have. So the point is, know the workplace. Understand the workplace. Understand about safety concerns. Now, this is me milking never mind. I won't say that. Understand the safety concerns. Again, talking to industrial hygienists and the safety professionals in the plant, you'd be surprised what goes on in the plant. Finally, it's about communication. Occupational environmental medicine, a cornerstone of it, I mean, obviously it's medicine, but more important, it's just as important, is communication. Communication with the team, with the employees, with the community. We're in transition in the workplace. We're seeing an aging workforce. We're seeing a diverse workforce. We're seeing various regulations coming in. We're seeing the change in the general practice of medicine. All those are going to focus on changes. That's where organizations such as this, where you can network, find out what the latest is going on. The transition brings opportunities. We've got specialty evaluations, programs going on about commercial driver and Maritime. We can ask Bob Bourgeois about that. Medical review officer exams. Both Chris and Doug have both been involved in that training program. So these are just some of the areas, these specialty evaluations. I liken it to the medical knowledge base as a brick wall. You take down the brick wall and you take the bricks, the medical knowledge, and you restack it for occupational environmental medicine. You look at it slightly different than the general practice of medicine. You'll hear more about that. So the key is to get on the escalator, get involved. We ask you to ask questions throughout the days of the meeting. People who have ribbons on, and Chris will have one very shortly, these are individuals in the organization that you can ask questions about. I don't know the winning lottery number, but I'll take a guess at it. Connect with others that may be experiencing the same thing right here in this very room. Understand that the traditional roles are changing, and it's no less for occupational environmental medicine. So for the next 4 days, look over the schedule, look at what's going on, get involved, talk to people. There's as much learning goes on in the hall sometimes as goes on in these lectures. So with that, I'll take a couple of questions while Chris, no, you're up next. Bob's got to go to the House of Delegates meeting, so I pulled him out of there. Doug is over at the House of Delegates meeting, so we'll let Bob go first. And then, but do you have questions of me? The only dumb question's the one you don't ask, okay? Okay, so we go right here. Now, we do have an interpreter for Dr. Bourgeois. He lapses into French every once in a while. So,
quick question. How many of you can hear me okay with this? How many of you are practicing full-time OcMed now? Okay, and how many of you want to increase your practice or learn more things about it? Pretty much everybody? Okay, good. Okay. A little bit about me. I started out in general surgery, but I hate to stand in one spot. So the nurses told me you need to get out before they ruin your personality. So I did that. Went back, did emergency medicine, and I worked in a trauma center here in Orlando, but I'm actually, by accent, from Louisiana. Married a girl who trained killer whales for SeaWorld. Worked for Martin Marietta, which is now Lockheed Martin, and Stan followed me over there. And he can tell you the beautiful golf course back here is now on property that we used to house Patriot missiles and Hellfire missiles, but we had to move because we were no longer out in the country. I do talk a little fast because I'm trying to stay in English. It's hard to do that in Louisiana because it's, according to most people, that's supposed to be our first language, but I'm not sure what we speak over there. Anyway, I'm in Morgan City, Louisiana. We're about 18 miles from the Gulf of Mexico. Everything below us is swamp or mud, so we don't really have pristine beaches. We did get involved a lot in the oil spill and got to do a lot on there. As Mark said, in maritime medicine, I've been doing a lot of that with mariners in the Gulf of Mexico, so I'm on a federal advisory committee for the Coast Guard through Homeland Security to write merchant mariner medical guidelines, and if you have questions on that, we have a seminar on that, I think on Tuesday, with the Federal Maritime Surgeon. So I'm going to go through this. If you have questions, holler, or we can do them right at the end, and I'll try and tell you a little bit of things to look at for your practice. And I have no financial interest. My disclosures, I have nothing to disclose. Objectives. The things we want to look at is how you evaluate opportunities in your area. Looking at different types of exams, requirements for specialized exams, different testing, ancillary services, that sort of thing. In your area, how many of you know who does the school district, either school bus physicals, for the CDLs, teachers if they have a work comp injury, slip and fall in the classroom? Who does drug screening for the bus drivers? Who does this drug screening for athletes or for school, the students? Those are things a lot of people pass over and don't even look at. And sometimes the school board may be one of the biggest employers in your area, but nobody even knows that that's a viable client. Municipalities, who does the city workers, for us it's parish workers, but everywhere else it's counties. Who does those folks? Who does the police, the fire, everybody else? Those are things to look at. If you're doing different types of exams, just in transportation, commercial drivers, federal motor carrier, FTA, intrastate, and then the school bus drivers. I mean, we have tons of school bus drivers, and even the coaches, the part-time coaches, the cheerleader sponsors, everybody gets CDLs, so we get to do a bunch of those. Railroad. For Coast Guard, if you have mariners, if you're on an inland waterway where they have tugboats and barges, you may not think that you're by a port, but they have a lot of those folks that live there. We have guys that work in the Gulf of Mexico that live in Montana. We have them that live in Maine, all over the place, and they have to go find somebody to do their physical. The Coast Guard is actually looking at a program similar to federal motor carriers to start having training for doctors to be designated examiners for maritime physicals. So that's something to look at too. The FAA, to do pilot exams, it's a little tougher. You have to be an MD or DO. You have to be asked sometime because it's by need in that area. If they need more examiners for the pilots, and it does require some training. The federal motor carriers training, we just had a class yesterday, and the exam is going to be actually mandatory where you have to be certified by March of 2014, I think. Different components of the exams. Vision screenings. Whether you're using a Snellen chart or you have a Titmus or an Optec or whatever vision screener, it's good to have something like that. The hearing testing we'll talk about. Blood testing, whether it's exposures or surveillance physicals or for wellness purposes. Urine drug screening, exposure, again, with some of the urine screens, pulmonary function testing, respirator fit testing, and then even some industries based on the job function require graded exercise testing. I was boarded in emergency medicine, before I was boarded in occupational medicine, and I tell people I've taken care of hundreds and hundreds of MIs, but I don't think I've ever caused one. So we don't do the testing in our office because we have 3 cardiologists about 100 yards past us, so we let them do it. With the vision testing, again, the screeners, the most common ones are either made by Optech or Titmus, and depending on what you're going to do, there are some specialized screens you can put in them, which are kind of nice. Some exams require special tests, whether it's crane operators, some of them have to have depth perception. For pilots, we have to do intermediate because you're looking at distance, near, and intermediate vision, which is when they're looking at the console and the instruments on the plane. The color vision testing, whether you're looking at just an Ishihara plate or for Coast Guard, for other things, you can look at the Farnsworth Lantern or the Optech 900 test looking at colored lights. So if you're a boat captain and something's coming at you in the dark, it's nice to be able to tell which one's red and which one's green. But we did have 4 different captains in 1 month that all failed the Ishihara plates, but when they did the Optech 900, the colored lights, they failed those also. And 2 of the guys said, "Doc, it's not a problem. I got this fella that always salesmith me. So at night, if I see something coming on the radar, I just get somebody to go wake him up." So that's got to give you a warm and fuzzy, Field of vision. Field of vision is important for pilots. It's important for drivers. It's important for mariners. So you need to be able to test that, whether you do it manually or you do it with a machine. Depth perception, same thing. With crane operators, if they don't pass depth, a lot of times they'll have 20/30 in one eye, 20/40 in the other eye. They don't require glasses, but they'll fail the depth perception. And they go to get glasses and both eyes are 20/20, they'll pass. So it's really not that hard to fix them sometimes. Hearing test. Generally, you either have to have some really quiet room or a booth. The booth and the audiometer should both be calibrated. If you're using microprocessors, you don't have to have anybody certified to do the testing, but they need to be trained to do it. And the physician can actually do the manual testing if you have a problem. But if you have folks that are KOC certified, then they can do that, and you don't have to step in as often. A lot of different exams require periodic testing, whether it's because of hearing conservation for OSHA or other things that companies have set up. Blood testing. Surveillance testing depends on the type, but you use lead, cadmium, different annual exams. We do a lot of executive physicals. If you have companies in the area that have execs and they're going somewhere else, sometimes because you're doing some of their other work, you can offer them executive physicals, and it's just a big wellness exam, but they want to keep those guys healthy. When Stan and I at Lockheed at Martin Marietta, we probably did 200 executives a year just to try and keep those guys healthy, because if you find something early, it's not a big deal. If you find something late, you don't get to buy green bananas. But it took us a lot of money. It was about $250,000 to replace some of those guys because of their experience and background and contacts. So it got to be important to the company to make sure they were healthy. And the way we did that is we didn't make it mandatory because it was a wellness thing, but you couldn't get your performance appraisal until you got your exam. So that was the incentive. Post-exposure, bloodborne pathogens. We take care of the hospital also. So they send everybody to us. So when we do that, if there's a needle stick, and even the ambulance services, we do those guys too. The funeral homes, let the funeral homes know you do that. You get some of those. Drug testing, pre-employment, post-accident, reasonable suspicion, randoms, follow-up, return to duty after being treated, going through rehab. And then we do a lot of the school districts, so we do a lot of these student athletes, both for private schools and the public school system. To do that, it's really important to be an MRO. If you haven't done that, great training here, great updates here. Every year they have courses to update you on the latest things coming out, and then the training's always ongoing. Any of the DOT exams, you need to be an MRO, so it's good to do that. We also have an MRO assistant in our office, so she helps us with a lot of things, and she's been certified to do that. And then we have collector trainers so that we can have everybody in the office that needs to be trained. We train them all in-house. So she's a trainer for the collectors. And we do the same thing with breath alcohol testing. We have our own trainers. SAPs. If you're interested in doing that, you can become certified to do it. It kind of takes you a little bit out of the loop when you're an MRO and a SAP if you're doing it with the same people, but you can do that if you don't have one in your area. And there may be a need for somebody in your area, because if they don't have one, a lot of folks may start using you to do some of that. With the urine testing, with some of the different exposures, we have refineries close to us. We have barges transporting fuel, diesel, all kinds of different things. So we see some benzene exposures from time to time. Fuel tanks, if you have tank trucks delivering, some of those guys will send people to you. And then also on physicals, whether you're a dipstick and macro, micro urinalysis on employees, it depends on the physical again on some of that stuff. So which ones you're doing and which ones are required. Pulmonary function testing. A whole lot of different exams require them. The technician should have gone to a NIOSH-approved course, and ATS gives guidelines for spirometers. They give guidelines for how to do the testing. And it's really good to just kind of get that going and do it right, because you hate to tell people you're doing things the right way and you're not, because if something comes up down the road and they start looking back at it, say, why'd you do it that way? Well, we thought that's how we're supposed to do it. It's a whole lot better to find out how to do it right. And the spirometers, we calibrate them daily in every fifth person just to make sure everything's okay. And we dump that right straight into our EMR. And so we have a record of doing that all day, every day. Same thing with the audiometers. We have a record every day that goes into the EMR that says we did a calibration on each of them every day. Fit testing. When you're looking at some of the PPE, the respirator standard lists how you do the protocols and whether you do quantitative or qualitative. We were doing a qualitative testing 3 different ways, mostly 2. We did irritant smoke, which corroded all the fans in the rooms that we're using because it turns to acid, and I got tired of replacing exhaust fans. So we mostly use just Bitrex now. And if you've never experienced Bitrex, it's the most bitter substance known to man. And if you get it on your hands enough times, you'll wear gloves. The quantitative measurements, if you're doing a porta count, or you're actually getting a measured fit factor, so you're measuring the difference in the concentration of contaminants in the air versus what's inside the mask. So it measures how much that mask is protecting that person. The air in our clinic is not dirty enough to measure it, so we actually have to burn candles to put a little soot in the air in the rooms that we do quantitative fit testing in. And we had to get unscented candles because we have too many candles burning. We train our nurses and our technicians to do the fit testing. And we have a whole bunch of different stations to do that. And then we also do those kind of things on site. So you can look at some of those kind of things. Because a lot of companies don't have somebody doing it for them. And a lot of them don't have them doing it right. When you do it, very, very important, you do the respirator questionnaire. The company is entitled to the first page of it, which is the demographics. But the medical part of it, the other pages, are for you. So we just give them a page. The page we have at the end says that they're fit or not fit for negative pressure respirators, positive pressure respirators, airline supplied respirators, SCBAs. So we have all these different ones listed, and it says okay or not okay for them. And then we also, so nobody ever says, you didn't tell me to quit smoking. We have a box that says advised to quit smoking. Because, the biggest thing everybody says when there's a respiratory issue is, I've been going to the doctor for 25 years and nobody ever said anything about smoking. So on our physical forms, there's a box to check off stop smoking and stop dipping. And we have a box on the respirator questionnaire, on the certification form that says stop smoking. Now, by rule, you do the medical questionnaire first, And if they're cleared, then you can do the fit testing and the training. But there are a lot of folks that are, some of them are vendors for the respirators, and they'll have their little van and they'll go out to the yard and they'll have people fill out the questionnaire, fit test them, and train them right there the same day. But it has to be reviewed by a medical professional before you do any of that. So, and that was one of the things at the OSHA breakfast in D.C. a few years ago. One of the biggest things they were looking at when they do audits is, was it done in the right order? Because they see in so many places where the guy really never should have been medically cleared, but he already had all this stuff done, and they issued him a respirator. So do those in order, and it'll keep you out of trouble. And when you tell companies that this is how it's supposed to be, and the folks doing it right now for them are doing it wrong, you may end up with that business. For the commercial drivers, Federal Motor Carrier, FTA is, the buses, and in the school board, I mean, we have tons and tons and tons of folks driving school buses, so that's been a pretty good little chunk of change. The interstate drivers, they're still using the DOT form, the Federal Motor Carriers form, and you need to remember this kind of same guidelines, but some of the states will give waivers or let people drive with, sometimes they're not as strict with the requirements as Federal Motor Carriers. And it varies by state, and it's just like with monovision, they may do something different from Federal Motor Carriers. But it's important to know what you have in your state, because if you're clearing them, you need to know the rules. For commercial drivers, you have to use a DOT form. If you don't have one, that's the link to get it. Know the regulations. There's a commercial driver, there's a medical examiner's handbook for commercial drivers on that website. The course is great. It's a good thing to take, and the testing is already started, so you can get certified. You need to be able to test vision, blood pressure, height, weight, and color vision. And then the individual owner-operators, if a guy owns one truck or two trucks, he still has to have a CDL, and they still have to be in a random drug screening program. But sometimes they say, well, hey, I'm the only guy. I say, well, then you'll be testing 100% a year. Yeah. So it makes them easy. For railroad, they have the forms set up. Some of it's by company. Dan? Is Dan still here? I think he stepped back in the meeting. You still need to be able to test the same things for them. Merchant Mariner, we're just revising the physical form now. Tony Alamo, who's also a member of ACOEM, and a couple other guys, Darren Dewey, and there's another bourgeois, Brian Bourgeois. See, everybody in Louisiana is either bourgeois, Boudreaux, or Thibodeau, so we're related somewhere. But we've all been working on the new forms and the new guidelines. If you look at the second site on here, the NVIC 408 is the latest medical advice or guidelines for merchant mariner physicals. And then the 719K is the physical form, and that's the one you have to use on licensed mariners. There is a 719KE entry-level form, but none of us will use it because you actually don't have to see the patient to do the evaluation. That's how little is on there. It just says that I think they're okay to, or I think they're fit enough to work on a boat, basically. And so some people will send in a stack of those and say, hey, can you sign these for us? These guys are all healthy. Here's $50 a piece. Don't do it. So we won't do anything other than the full form. Again, there you need a bit of test vision, blood pressure, height, weight, and the color vision. The testing methods are listed on the front of the form, the physical form. If you don't have one of the tests that are listed, don't do that. I mean, issue high plates, if they fail it, everybody's got those, but if or even the Titmus screener or the Optec screener has they have the same screens for color vision. So if you look at that, if they don't pass that, then they either use a Farnsworth lantern, which they don't make anymore, or the Optec 900 is a similar thing. It shows colored lights. The Farnsworth D15 are those colored caps that you put in chromatic order, and that's not acceptable. That's not the color lights. It's only acceptable for engineers, for the guys that are doing wiring down in the ship, but not for deck officers. Immigration exams. You can become a designated civil surgeon. So if you're in a place where you have a lot of immigration work, you can do that and get on the list and start doing a bunch of those. We don't, kind of too busy really to pick up one more thing just now, which is a good place to be. But I think if I were trying to get more business in the door, that's not a bad place to start. IMEs. A lot of insurance companies are asking for those. Even a lot of the work comp, whether it's state work comp folks or whatever, will ask for them. It depends on what edition of the AMA guides, too, that they're using. So you may need to have one set for this state and one for another, because it depends on what their legislature said is the official version for their guidelines. And those, you know, they can keep you busy doing those. But if you like to do a big full exam and you like to write everything up, that may be another way for you to do something too. There are some ways to be certified in it by different entities. Surveillance physicals. The two biggest things we do are probably hearing conservation and the respirator work. On those, we're doing the questionnaires and the fit testing. We don't do the training in the office. We do off-site fit testing. We do off-site PFTs. We do off-site audiograms. It does kind of keep everybody happy, because those guys aren't coming into your office, leaving the work site and waiting. If you want to do any of the other OSHA-required surveillance physicals, if you find out what the companies in your area are doing. I mean, some of them are working with things that you may not even realize they're doing, but the more you get involved with that, the better. One thing for us, every area is different, but the Rotary Club has all these guys from industry, and they meet there all the time. American Petroleum Institute. We have all these different organizations. They have a lot of business folks in them. If you're in something like that, sometimes word gets out that you can do some of that. So on the OSHA exams, there are tons of different things you can look at, and you can look them up by the regulations and figure out which ones you're interested in or which ones you have need for in your area. Crane operators. They're crane certifications, but it's mostly vision and hearing, and there's not a whole lot, but it depends on which certification the folks that you're working with do. But what we do on those, and most of the companies have asked us to, they're using the same criteria as federal motor carriers. But what was funny is all these crane training programs were saying, you need to go get your crane operator card. So they'd have them go in, they'd give them CDL forms and say, go get this physical and get it done. Well, it's kind of like having a secretary do a DOT drug screen because she works for a boat company. If she's not a crew member on a vessel, she doesn't get a Coast Guard DOT drug screen. If you're not driving a truck, if you're not required to get a federal motor carrier's physical, you probably shouldn't do that, because you have somebody, you're saying you need this federal physical. Well, you don't. So what we did is we changed the format of the physical, and everything on there now says crane operator. And the card that they get says they're certified, medically cleared to operate a crane. So it has nothing on it that references a federal program, driving a car, driving a truck, or anything else. And so now that's what all the crane training programs, that's what they're using. So that worked out real well. Fitness for duty evaluations. Those should be done prior to job assignment, whether it's a new job requirements. If it's really fitness for duty is pre-placement. If they're going overseas, going to remote locations, doing some hazardous duty. We have folks working offshore, And it might be an hour and a half helicopter flight out, but in bad weather, it might be 3 days out. We have folks going overseas, and they're working 200 miles off the coast of a place that takes a helicopter flight in, a day drive to the next city with a hospital or an airport. So those guys may be, again, 3 or 4 or 5 days out. And we've had a lot of problems with those sort of things. So, you know, people that are on anticoagulants, people that have defibrillators, diabetics on insulin, a lot of different people that have bad problems that can get bad in a hurry. I mean, head problems get bad in a hurry. You may not want them in those areas. And so you kind of help the companies decide who's fit to work in those areas. Return to work after injury, illness, whether it's work-related or non-occupational, you still want to see that. We've had guys that have gone offshore. They had a PTCA and a stent in a coronary vessel on Friday, and on Monday, they caught a helicopter offshore at 6 in the morning because the doctor said he's released, he can go back to work, so he did. So he's 2.5 hours out by helicopter, has chest pain because the stent occluded, and they have to fly him in. And those flights, on average, are $32,500 per hour each way. So 5 hours total flight. So that's just the charge for the helicopter, not all the medical stuff on top of it. So it is really important to make sure that when doctors are sending somebody back to work or saying it's okay, that they know what they're doing. One of the issues with that right now, on federal motor carriers, on Coast Guard, there are time frames when you have to wait this long before you come back from a heart attack or from cabbage or from a stent. So what happens, these guys will see them on Friday, release them, which cuts them off disability. They're not on short-term disability anymore. And you're saying you can't come back to work yet. So the insurance companies are saying, well, hey, we got a note that says he can go back to work. So it ends up being a big contest. We're getting ready to do grand rounds in Houston for the big heart center. And we're going to do that occupational medicine talk to let them know what the timelines are for different entities, for different cardiac conditions, and something about the remote work and overseas work, so they know not to ship people out like that and just it kind of dumps them in a no man's land. Job modifications. Sometimes they'll bring people in back part-time. Sometimes they have some temporary duty assignment. Sometimes they'll have a permanent duty assignment change because of the nature of whatever happened to them. Workers' comp, injury, illness evaluations. Sometimes you get consults on it to find out somebody else who's seeing them. They want to know if they're doing the right thing or if they need to do something different, if they missed something. Again, the fitness for duty. If you don't know what they do, it's important to know, because a lot of times people will say, hey, there's no light duty where I work. I mean, Stan and I had one guy, one of the orthopedic docs around here, because we all had secret clearances to work there. He didn't get to go look at the guy, but we finally got him on a tour of the plant because he would not let this guy off restrictions, because the poor fella had to lift 108 pounds by himself 8 times an hour. So we were allowed to bring doctors in to tour the plant, would bring them in, feed them lunch, walk around in the sanitized areas. So when we walked around to where this guy was working, I kind of accidentally stopped to make sure he could see him. He says, that's my patient. I said, yeah. He's watching him. He pushes a button. The hydraulic lift picks up the 108 pounds, pushes a button, it pushes it over, pushes a button. So it was an 8 cycle an hour job, but his 108 pounds was pushing a button. And when he saw him go through one cycle and then go through the next cycle, he says, do you mind if I go talk to him? I said, I'd love for you to go talk to him. So he did, and when he tapped the guy on the shoulder, it was priceless. The other thing, too, is on other docs with no occupational medicine experience, same kind of thing. Teach them what we do. Teach them what the guy does. We had a guy that was released. He went a minute 26 seconds on a treadmill. So stage 1 of Bruce, minute 26 seconds. Claudications, chest pain, dyspnea, and 4 millimeter ST changes. But he says, I'm a boat captain. All I do is sit on my behind, smoke cigarettes, eat donuts, and drink coffee. And the cardiologist's response when I asked him, why would you clear somebody with that? He says, I'm so glad you caught it. Now, if had they not caught it, the guy probably would have died on a boat. On the work comp, recordable versus compensable, a lot of times I ask you what's what, and a lot of times there's not a good answer. Sometimes it's easy, sometimes it's not. The boat captains, they can come under multiple different agencies. They do a DOT drug screen. The Coast Guard's now under Homeland Security, but for the drug screening, it stays under DOT. His license is under Homeland Security and the Coast Guard, but OSHA has a memorandum of understanding with the Coast Guard for record keeping and everything else on vessels. So it may come under 3 different things. If an OSHA inspector ever comes to you, because they do audits around us all the time, they present the credentials, and they're pretty. And then they give you a medical access order, and they want to know if they can look at these records. The employee has a right to say you can't do it, but they do bring them in. And then the access order actually specifies what records, what time period, what injury, or whatever. Case management, whether it's for the company, group health, medical leave of absence, workers' comp, a work comp network, whether it's for your clinic, through your clinic for the hospital, insurance company reviews, whether it's work comp or even group health. Travel, we do a ton of travel because we have so many people in the oil field working worldwide, and there are a lot of different things you can do there. The only one that you have to get a stamp for is yellow fever, so you have to apply through your state for that. And a lot of different travel medicine services so you can keep up with what people need. Routine and seasonal immunizations, flu vaccine, we do that for companies, for schools, for a bunch of different folks. Meningitis vaccines for the college students. We do a lot of TB for healthcare workers and a lot of the food service people offshore. They require that now, and there's a national shortage on the PPDs, so there are two different ways you do it with blood. And in Hep B, we do all the medics, fire departments, the emergency response folks at the casinos, and a bunch of other places. Imaging, in-house, we just have plain x-ray, but some people have MRI and CT. My experience with the standalone clinics that put in MRI or CT or physical therapy was that the companies kind of look at you like you're feeding the machine. And if I'm going to order 4 MRIs a month and I buy a machine the next month and still order 4 MRIs, now 75% of them will because I was trying to feed the machine. So we've never got involved with that just so I don't have to have that discussion. Functional testing, there are different ways of doing that. We actually built a setup to do it for the Coast Guard where we have stairs, and we actually had to put a runner in the middle because we have some big boys. My BMI record last year was 67.3. My BMI record in February, 70.8. My dad said the guy was markedly under tall. We have vertical ladders, we have lift stations, push-pull stations. That's a 24 by 24 hatch that the Coast Guard says you need to be able to pass through. When a guy gets stuck in there and says, can you give me a minute? I said, I could give you a case of KY jelly. You're still not going to get through that. Some places, instead of doing that, we're doing a 24-inch hula hoop. It's not acceptable because it's like somebody putting on a big girdle. It's pretty, though. Vertical ladders. And if it says you have to climb 16 feet, make them going up and down 8 foot twice without stopping. You can do all that kind of stuff. And these are easy to build. It's not really expensive. Well, not easy. I didn't build it. And then we have swing ropes where they got to hang on it because they got to swing from a boat to a platform. They got so many seconds. Close. In mobile services, on-site testing, audios, PFTs, respirator fit testing, drug screening, urine, hair, all that stuff. Breath alcohol testing. Some people even do physicals on site too. Some investment depending on what you're doing because you're duplicating some of your equipment. I always try to make sure that everything I buy interfaces with my EMR. Wellness programs, clinic-based, single company or group. What we do with those is we'll ask them to give us a insurance run by DRG, top 20 or top 50 or top 100 most expensive codes and most frequent codes. And we do it on group health and on the work comp side. And then we look at that and try and help them figure out what things they can modify to make some improvements. Consulting, you do all kinds of different things, writing policies, work comp determinations, leave of absence policies. So this is all kind of fun too. Dispensing medicines. We don't actually dispense anything in-house because, again, some of them think it's convenient, some of them think you're just trying to write those prescriptions to get more business, so I don't do them in-house. But you can do all those sort of things. And Swamp People, if you see Troy on Swamp People, the one that says shoot them all the time, his kids and my kids went to school together. He's actually a pretty bright guy, but he's funny as can be on TV. And the guys on Duck Dynasty live right by my brother's house. And so they're putting Louisiana on a map, good, bad, or whatever, but they are funny. Any questions? All righty, thank you.
Next, we've got Doug Martin coming up. Doug is a reformed family medicine doc, I believe, is the best way to do it. And he's been doing occupational medicine extensively for 18 years now. This guy's got a lot of wisdom. Please listen to what he's got to say. He's not from Louisiana, so he's from Iowa. He's going to speak English.
Thanks, Mark, and welcome everybody. And I apologize, I kind of running back and forth here between the House of Delegates, which is next door. But I wanted to kind of bring a little transition between Bob's and Chris's presentation for you today and kind of give you sort of some background with respect to how in the world can a primary care doctor survive in the world of occupational medicine. And I know a lot of you that are here are primary care-based physicians or nurse practitioners, PAs, and so forth. And it's kind of interesting. When you look at the dynamics of who provides occupational medicine care in this country, it's not primarily the Occupational Medicine Board of Physicians. I know that surprises a lot of people, but there's much more workers' compensation care that is provided by primary care in this country than any other discipline. And I remind people of that because I think sometimes people just don't understand that. Statistically, you have to look at it from the standpoint of our training programs. In the United States, we graduate about 60 to 80 occupational medicine residents a year. Obviously, there's much more demand for occupational medicine trained physicians than that, and that goes without saying that you're going to borrow from the other disciplines, whether that's family medicine, internal medicine, emergency room, PM&R, or what have you, in order to fill that need of providing those occupational health services. To give you a little bit about my background and sort of how you can get involved with these types of things, I'm primarily a clinical-based guy. I'm in the office every day. I see anywhere between 20 and 25 patients a day. One of the things that you have to understand about Sioux City is we're our agricultural capital of the Midwest, okay? Meatpacking is my life, all right? I happen to take care of the largest meatpacking facility in North America. All right, isn't that kind of cool? All right, we get 7,000 employees in a Tyson plant in Dakota City, Nebraska. So guess what? I get to deal with a lot of musculoskeletal kind of problems. Now, if you enjoy musculoskeletal medicine like I did going through my family medicine residency, and yes, I thought about taking a sports medicine fellowship. A lot of family doctors that go through family medicine residencies that like musculoskeletal-based medicine kind of go in that particular area. I thought to myself, you know, am I going to go do that and maybe just see the athletes and take care of the home team on Friday nights and this sort of thing? Or is it something that I want to do a little bit more with? Well, that's how I got interested in occupational medicine. So I went through a family medicine residency. It came out of that. I went to Davenport, Iowa for that. Came to Sioux City, Iowa, and I had these grandiose thoughts when I started my practice that I was going to do a little bit of both, okay? And as a matter of fact, when I started out, I kind of said, well, you know, I'll probably do 75% family medicine and maybe 25% occ med. And then about a month later, that became 50-50. And then a month after that, it became 100-100. And therein lies a problem. It's like, oh my gosh, now what do? I'm faced with a dilemma. Do I go family medicine? Do I go occupational medicine? Do I continue to try to maintain both of these things? And basically, I made the decision to go occupational medicine. Why did I do that? Number one, I wanted a family. Okay? You've heard over and over and over about the trials and the tribulations of the family doctor and how many different things that you have to take care of and how your time is precious, right? So, you know, although I kind of like to take care of kids, I didn't really like to go to the hospital at 2 o'clock in the morning and do a spinal tap on a 3-month-old. I didn't really want to do that anymore. Yeah, I delivered kids every once in a while. It wasn't a big part of my practice, but I certainly didn't miss that. So one of the things about occupational medicine is that it's pretty much an 8-to-5 job. My wife really liked that part, okay? And my kids kind of liked that part. So that was kind of an easy sort of transition for me. But that wasn't the end of it. You know, I kind of started thinking, well, you know, I'm just going to be one of these clinical OCMED guys that does work comp, injury care, and, you know, we're going to just kind of do that for the rest of my career and call it a day. Then I started to get more and more requests to do more things. Companies all of a sudden wanted me to do impairment ratings. You heard Bob talk about doing impairment evaluations. And lo and behold, I went to a couple of courses and learned about the AMA guides. And when I started in Sioux City, I had to learn every edition because South Dakota used 4th, and Iowa used 5th, and Nebraska used 6th. And it's like, oh my God, now I got another skill set that I can use. So suddenly we started to do more and more impairment evaluations in the workers' compensation system. And then an interesting thing happened. I started to get these phone calls from attorneys. Dr. Martin, we know that you do these impairment examinations for work comp. Would you like to see some patients in the personal injury field? I said, well, gee, I really don't know what that's about. So can you tell me more? So then I started to get into the independent medical examination realm. And if you like that sort of thing, if you have a little bit of a detective streak within you, and you like to take complicated pieces of information and complicated histories and kind of sit back and think about all those types of things, that's something that, you know, you're probably going to do pretty good at. The other thing about the independent medical examination that's interesting is if you like to write, this is a wonderful thing for you to get into. Independent medical examinations are noteworthy with respect to their reports. They can be lengthy reports, but if you're a good writer, this is something that really you will do very, very well at, okay? Then when I started to get into more things, we had this sort of epiphany in Sioux City that all the companies wanted to do drug testing all of a sudden, okay? Post-job offer, random screens, this sort of thing. And I became more and more involved in the medical review officer arena, okay? So I went to the ACOEM training courses, I got my certification. 15 years later, I'm chair of the MRO section. So, you know, hey, how does that work? Well, it works because you have an interest in something, and if you're really passionate about it, and you're kind of interested in educating people about it. And one of the things that I will tell you is my parents were both educators. My father was a superintendent of schools. My mom was a teacher. 3 of my 4 grandparents were teachers. Didn't my parents look at me weird when I said I was going to medical school? It's like, you're going to do what? But, hey, I try to explain to them, part of being a doctor is educating your patients. Part of being an occupational medicine physician is educating everybody that's involved in the process, not just patient, not just employer, educating attorneys, human resources managers, insurance representatives. All these people really could use a lot of information and expertise that you can bring to the table. So as a clinical-based occupational medicine doctor, I get to do all these things. And I'm kind of in a unique location in Sioux City where it's not so big that I have a lot of competition, but it's big enough where you have to have somebody that needs to do all these things. And believe it or not, in Sioux City, I get to do Coast Guard physicals. Why is that? Because we have casino riverboats. And riverboats have captains. And you might say to yourself, you know, why in the world would somebody from Sioux City ever do a Coast Guard physical? Well, I get to do 2 a year. All right, so that's kind of a fun thing. And a lot of things that Bob talked about, I will tell you that as family physicians, primary care doctors, nurse practitioners, PAs, you're going to do really well at. One thing that I will tell you over and over and over, going across the country and talking to a lot of different physicians, primary care providers, you know how to listen, you know how to do a good physical examination and a history. These things are critically important in the world of occupational medicine. I cannot underscore that enough. So you already have a leg up on folks with respect to that particular component of it. And the other thing about this is in the world of occupational medicine, it's kind of like a menu, okay? I'm not suggesting that you all have to follow my track and kind of do everything in occupational medicine, but you can kind of do the things that you enjoy. So if you like musculoskeletal medicine, you can, do the work comp injury care part of it. Maybe not worry about the other things if you want to do other stuff. If you're really into toxicology type of assessments, I didn't know a darn thing about toxicology, and through a family medicine residency, they never taught me anything in that respect. But I got more information from coming to some of the courses that we have and really learned it sort of on the job, okay? So if you have an interest in that, that's wonderful. If you want to get into the drug testing area and arena, medical review officer is a simple thing to do. Doesn't really take a lot of time from the perspective of patient time. I mean, you're basically performing an administrative function, but you know what? It can be fulfilling because it's a role that's very, very important. One last thing that I'll leave with you before I turn it over to Chris is I know, being in the family medicine realm for a while, the issue of payment and reimbursement was an issue, okay? I don't think I have to tell anybody here about, declining reimbursement rates for Medicaid and Medicare and the constant battles that you have with insurance companies over discounting and all those kinds of nasty things. I lived that, and I'll tell you, occupational medicine is not completely immune from that, but it's a darn sight better than what you will find in the primary care arena. So occupational medicine, workers' compensation care, they pretty much pay the bills. Okay, we don't have to struggle a lot in my area with getting decent payment and decent reimbursement with respect to those types of things. So I would encourage you that if you want to try some of these things, dip your toe in the water, as I like to say. See how it is. If you don't like it, fine, call it a day. Go do something different. That's okay. But if it's something that you enjoy or something that you say, hey, this is something I really like and I think I'm good at it, go for it. Why? Because we need you, okay? If you look at the dynamics of what's happening with physician supply, I don't have to tell you what that looks like. There's going to be less and less physicians to take care of more and more people, all right? The dynamics are out there. Same is true in occupational medicine. We're going to need people outside of the traditional occupational medicine training disciplines to get involved in helping us take care of the workers in this country. It's a very important thing that you're doing. I'd encourage you, if you're at all interested in doing any of these things, to, again, dip your toe in the water. My contact information is everywhere. martindw@stlukes.org is my email address. I try to make myself available for practically everybody. It's one of my downfalls. My wife will tell you that I do not know how to tell somebody no. And it's one of my character flaws. If you have a question, if you want to know, hey, Dr. Martin, how did you do this? Can you help me with trying to get involved in doing some of these examinations? Who do I contact? What do I do to try to get started? Or can you point me in the right direction so that I can learn more about things like MRO or things like independent medical examinations? I can help you with that. And if I don't know the answer, chances are I probably know somebody who can give you the answer. So I always try to make myself available for folks because, I've been there. And one of the things that I would tell you is I want to make sure that we continue to have a nice pipeline of physicians and providers going forward that are able to do this type of medicine and do it well. So with that, I'm going to turn it over to Chris. Thanks very much.
I'll just use this mic.
He's excited about occupational environmental medicine, can you? This is an evaluation form. It's in the back. Please give us feedback. It's very important about putting this together. Are we hitting the mark? how can we do better. So I would appreciate it if you would fill that out and also sign in the log sheet for us, please. Next up is Dr. Chris Stewart-Patterson, and now he's going to give us the Canadian perspective, but he's also co-chair of the Foundations course here at ACOEM, where we do go in more in depth in a lot of these topics. Chris, it's all yours.
Good morning. Can you hear me back there? It's all good? Okay. Like Doug, I come from a general practice background up in Vancouver, BC, and I first started doing a little bit of occupational medicine 1 day a week. And I got more and more work and got more and more interested. So basically, over 5 years, I would drop a day of general practice or emergency and pick up a day of occupational medicine. After about 5 years, surprise, I was full-time occupational medicine. So that was about 10 years ago. So now I'm one of the senior occupational physicians in Vancouver. I look after the Royal Canadian Mounted Police, Canadian Military, Vancouver Fire Rescue Services, and then there's a whole bunch of companies that only need an occupational physician about once or twice a year. I sort of call it a rent-a-oc-doc thing. So they only call me when they're in trouble, and then I'll see one of their employees and assist in sort of a return to work. Now, your nurses, your doctors, your PAs, this is what you're doing now. This is your work, right? You're using your intellect to diagnose, to treat, using your heart to extend compassion and reduce suffering. Well, when you go into occupational medicine, you're going to do exactly the same thing. You're going to do exactly the same thing. The skill set that you have, the knowledge you have, the strength that you have are transferable over to occupational medicine. We're going to add a few interesting layers of other information and skills that I'll tell you about, but the core job is the same. With one exception, in occupational medicine, you get to look after populations. You get to look after employees in companies. And occupational medicine has a proud tradition of working with unions, working with government, working employers to make the workplace more safe. So we've made a little bit of progress, right? This is the Rockefeller Center in 1932. This is the guys on their lunch break. So some of the things we've made progress in, you can probably just tell. We wear hard hats now. We have harnesses in the workplace. We still smoke sometimes, but we don't smoke in the workplace anymore. And my personal favorite, we look at the guy on the left over here. We've been strongly discouraging maybe suburban at lunchtime. We've made some progress on that. So you do get to look after populations as well. So it's a blend of knowledge and skills. You've already got some skills, but occupational medicine is going to give you some new knowledge and skills. You're going to learn a lot about what people do in their jobs, and that's really interesting sometimes. You're going to also learn about the risks involved in some of the safety-sensitive jobs. And occupational physicians are always interested in what people can do, or if they're sick or they're hurt, what they can't do, because we're going to turn that information into how can we get them back to work in a safe way. We use things called activity prescriptions. Sometimes we even write it down in a prescription. This is what I want you to do. I want you to go out for a walk. I want you to garden more. I want you to increase your function. And occupational physicians are very bullish on early focus on a safe return to work expectation. So for me, one of the perks of being an occupational physician is you get to do really, really interesting job sites. I've been to slaughterhouses. I've been to the Secret Service training facility. I've fired fake guns at their video training things and so on. And here I am at the Washington, D.C. Fire Academy. So I've read the job description of firefighter, and I know that the stuff that they wear weighs about 50 pounds, and they have to carry about another 50 to 100 pounds. Well, let me tell you, it really came alive here. So this guy is looking at me, and I'm wearing 50 pounds of stuff now. That's the personal protective ensemble. He's telling me to take another 50 to 80 pounds of hose, and he's going to run behind me while I run up and down 3 flights of stairs. So he knows I really get what these guys do for work, right? Anyway, it was a fantastic day out. And if you do occupational medicine and you have industries in your community, in your town, I strongly encourage you to get out. You'll get a lot of street credibility from the workers that you've actually been out there, and it's usually a really fun and interesting time. And you're always welcome, right? They're delighted that the physician is interested in what they do. So because I look after firefighters, and you guys sort of a general idea what firefighters do, I'm going to use firefighters as an example. We're going to talk about musculoskeletal assessment and return to work and psychiatric assessment and return to work. So with firefighter occupational factors, there's all sorts of interesting things that you're going to add to your general knowledge now. So what's the impact of shift work? What's the impact of shift work on obstructive sleep apnea? What's the impact of shift work on someone who's got depression and insomnia? Do they need a restriction from that for a while? What about heat stress? If they're a firefighter and they're on sort of a high dose of diuretics, that's going to affect their dehydration status, and these guys have to take breaks from firefighting to hydrate, right? If they have post-traumatic stress disorder, which even though they're a tough crew, men and women in firefighting tend to have a bit more post-traumatic stress disorder than the general public because A, traumatic events that are threatening happen to them, and then also the witness traumatic events happening to the public or maybe to their co-members. And the issue of myocardial infarction is really fascinating. This stuff kind of blew me away. Dr. Kales is an ACOEM member, an occupational physician at the Harvard School of Public Health, and he published a study in the New England Journal of Medicine about 5 years ago. First fact is that coronary heart disease causes about 45% of firefighter deaths on duty. The remainder, of course, are probably injuries, but it's a pretty high number. So Dr. Kales and his co-investigators looked at 3 groups of data. There was a municipal data in Cambridge, there was sort of a metropolitan set of data, and there's a national set of data. And what they found for the odds ratio of 1 is just sitting in the fire hall, doing nothing, cooking, talking to your friends, maybe watching TV. As soon as the alarm goes off and you're sliding down the pole and you're in the truck on the way, the odds of having a cardiac event go from about 3 to 14 times as high as sitting in the fire hall. And here's the cruncher. When you're doing, we call it fire suppression, when you're fighting fires, when you're out there in all that personal protective gear and the heat's on you and you're working really hard and you're scared and you're stressed, the odds ratio, unheard of, 12 to 136 times. Pretty big odds ratio. So that's why, with firefighters, we're really, really focused on cardiac prevention, right? It's important for everybody. You can see it's super important for this particular population. So we already talked about the demands. You know that I learned it firsthand. The SCBA, the personal protective gear, weighs about 50 pounds. These men and women are carrying either 20 to 40 pounds of tools. They're required with that gear to be able to go up 6 flights of stairs. So it's rated as very heavy physical demands, about the heaviest job you can do. So they have to be able to lift up to 100 pounds. They have to be able to push and pull up to 200 pounds. They have to be able to work from heights, from the tops of ladders and so on like that. So you start to get a sense of just how hard a job this is. These men and women are like elite athletes, right? So it's sort of the usual kind of injuries, that strains, 24%, wounds, which would be cuts and scrapes, 18%, burns, 14%. And mostly it happens to the upper extremity, the next most common the lower extremity, next most common the head. Now what I'll say, there's low back pain occurs as well. Low back pain is one of the leading reasons for early retirement in firefighters. So we take these folks and we have to get them back to work. We're occupational physicians. We're bullish on rehabilitation. And ACOEM has issued a statement about staying at work, that's what SAW means, return to work, that's what RTW means. And the statement was issued in 2006, and it's a worthy document. But 2 of the sort of the highlights of that document are unnecessary prolonged work absence from work can cause needless harm to a person's well-being. And that's basically based on the Waddell and Burton report out of Great Britain. They did a massive tome of about 100 pages where the bottom line was worklessness is detrimental to people's health. They lose money, they lose self-esteem, they lose social contact. So it did a very, very good review of the existing literature, and that was incorporated into the ACOEM statement. And for many employers, they begin the return to work efforts in the first day of absence or within the first 72 hours. So as soon as someone's off work, if there's a reasonable chance of them going back, we want to start to focus on return to work as soon as possible. And there's been similar sort of endorsements and statements by the American Medical Association, the Canadian Medical Association, and the American Psychiatric Association. And this is why. This is unpublished data from WorkSafe BC up in British Columbia, where I'm from. So you can see that the probability of return to work as time goes on, gets less and less and less. So there's bidirectionality, right? There's some catastrophic injuries in there that are not going to go back to work. But there's also evidence from the Waddell and Burton report that the longer you're off work, the harder it is to get back. You get deconditioned, start to put on weight. There's that whole psychological set that you're just not used to going back to work. So that's some of the evidence basis of we try to focus on a return to work as soon as we can in a safe and timely manner. So just a little bit about nomenclature. Impairment and disability have some colloquial meanings, but in occupational medicine they have really specific meanings. So impairment is about an inability of a part of the body to work. Impairment of the arm, impairment of the back, impairment of the brain. And given that you have some impairment, disability is about the impact of that impairment on your duty. It could be your job, or it could be your role as a parent or a spouse. So impairment's what's wrong with the body, what's not working about the body. Disability is how that impacts your role. So let's take a test case. Let's take a rural family dog, and he or she breaks his non-dominant arm. So they can still write, right? So they have multi-different tasks. Can they do a surgical assist with a broken arm, with the impairment of a broken arm, because they have impairment in strength, reduced range of motion, they have impairment in pain? No. They are disabled as a surgical assistant. Can they do emergency medicine? Probably not. So they're disabled as an emergency physician. Can they deliver babies? Well, you're not going to want this person to deliver your baby, right? So let's say no, disabled from being delivering. Can they be a family doctor? Well, if they're working with a group practice and they get some accommodation from their colleagues and doing maybe the pelvic tests and so on, and they can do some one-handed jobs like look in the throat and so on, yeah, with accommodation, they're not disabled for being a family doctor or a GP. And they also lecture medical students, provided they're not in too much pain or not too doped up. Can they lecture medical students? Yes. So the same person with the same impairment is disabled from several jobs, but with accommodation they can do their family practice role, and there's really no problem with them being a medical lecturer with their broken arm. So I hope that example makes it come alive for you. So I've talked about how doctors focus on function, how occupational physicians focus on function. I'll share my first epiphany and focus on function with you. So as soon as I graduated and completed my internship, I just wanted to go up to the north in the Arctic. I mean, it was just fantastic. And basically, as long as you have an MD and a pulse, they're going to hire you, right? Because they're always looking for people up there. So I went up to many places, Baffin Island, up to the town just short of Alert Bay as well, Grise Fjord. But I went to Fort Smith quite a few times, and I got to know the nurses there. It's a small town, 2,500 people. Call is 1 in 1 or 1 in 2 or 1 in 3. And there's drinking and there's fighting, so, you know, you get called out a lot at night. So in the beginning, the nurses were very respectful, and they said, you know, would you come out? But as we got to know each other, they would just say, get in here and hang up on me. And I would trudge into work at -30 with the northern lights going above me. It was a wonderful place. So I went back many times. So about my 4th or 5th visit, the phone rings at 3 in the morning. And we're back to, do you think you could come in? And I'm thinking something's up, and I go, yeah, what is it? And they go, well, it's a dog. So understand, there are no vets in these towns, right? So I had to deal with the vet in Yellowknife. So people would bring their poodles and huskies in and so on, and the vet would tell me, it's the same as a person, just do your thing. No, here's what you do. Or it's out of your league, tell the person to come and see me in Yellowknife. So, yeah, I did dogs. And she said, well, it's not just any dog. This is like the lead sled dog of the Northwest Territories. This is a celebrity dog. So anyway, okay, I'm coming in. So any of you remember that TV show, Northern Exposures? Yeah, this is a total northern exposure scene. So we go into the trauma room, and I have a family practice resident with me, which is great. So we're gowned up, and the ambulance backs up, ambulance door opens. The dog is on the gurney. The 2 seatbelts are done up, little oxygen mask on the dog. The paramedics are fiddling with the dog. So I've called the vet, and the vet goes, well, in ATLS, you do stuff on dogs, don't you? It's the same. Just run your ATLS protocol on the dog. If you need to sedate him, use a ketamine dose. And I'm like, okay, I can do that. He forgot to tell me one thing, though. So anyway, we bring the dog in, and I'm amazed that the x-ray tech knows how to do a chest x-ray in a dog. So the dog has a pneumothorax, and it's a bad one. It's like a tension pneumothorax. And I'm like, okay, I know what to do about that. I turn to the resident. I go, have you ever done a chest tube? He goes, no. I said, doesn't get any better than this. First chest tube on a dog. Next time they ask you, you can say, oh, yeah, I've done a chest tube. Anyway, the resident does a very good job on the chest tube, and he gets it all sewn in and so on. So we let the dog sit up on the trauma table. The owner's there. the resident's beaming with pride with his new chest tube. But the vet forgot to tell us one thing. The dog takes one look at the chest tube, reaches down, rips the whole thing out with his teeth. The dog forgot to tell us to put one of those cones on, right? So it's 3 in the morning. It's a 30-bed hospital. The dog leaps off the trauma table and is running through the hospital. In and out of the geriatric ward, all the Alzheimer's patients are waking up. We're chasing the dog. Whenever we get close to the dog wags its tail, jumps, runs away, playing tag. So after about 2 or 3 minutes of this, I go, this would be pretty serious on a person, but this dog's function is fine. This dog is having a good time, so I'm not so worried about the pneumothorax. So I kind of turned to the owner and said, let's just hang out for a couple hours, watch the dog, and I'm sure you're going to be fine. Dog was fine. We went home. So bad case, pneumothorax, dogs playing tag really wasn't the problem. And one of the reasons we focus on that is the diagnosis doesn't give you the impairment or the function. I mean, let's talk about a myocardial infarction, right? So the function after myocardial infarction ranges all the way from dead in 2 days from post-MI complications to congratulations, you ran your first marathon 2 years after your first heart attack, right? So the diagnosis doesn't give you the degree of impairment or the loss of function. So function is really important to occupational physicians. That's one of the things we're sort of good at assessing. And we really focus on it in terms of return to work. And we sort of look at return to work as part of the treatment, right? And we talk about an activity prescription. So activity prescription is what the patient should be doing for their recovery and preserve their well-being. So someone's got some low back pain and they're just lying in bed. We're going to say, let's get out. Let's do a little bit of gardening. Let's do a little bit of walking. What the patient should not do because of the medical risk. Well, we've prescribed them maybe opioids or gabapentin. Well, they should not be driving, right? So we're going to say, someone else is going to have to drive here for a while. What the patients can or cannot do. Well, I know you could lift 100 pounds before you hurt your back, and you've got sciatica now. You're only going to be able to lift about 30 pounds for a while. So you just can't lift more than that. You just don't have the strength, and there's too much pain. And whether or not they're willing to tolerate the activity. When we're talking about a return to work with some pain, we have to make a reasonable assessment in terms of their capability, what they can do for 4 to 8 hours, as opposed to a functional capacity evaluation may tell us that a person with rheumatoid arthritis can pick up 20 pounds 4 times, and they're being told that they can do this occasionally at work, but we're not going to send someone like that back to a warehouse where they're going to have to do it all day. They can do it occasionally. So that brings us to these sort of classic work fitness terms, and you'll see these in some occupational medicine reports, and they have pretty specific meanings. So capacity is what they can do. Limitations is what they can't do, and often if they've hurt or injured themselves, they now have limitations. They can't do as much as they used to be capable of. Restrictions are what they can do, but what they should not do. If they have a new onset seizure, they're capable of driving, but there's a 1% chance that they're going to have a seizure and black out. So they shouldn't be driving until X amount of time has passed and they're on stable seizure medications. And accommodation is, can the worker or the employer or the union sort of accommodate the restrictions and limitations in the workplace? Can we send Joe or Jane back to work with reduced lifting? So the limitations and the restrictions kind of turn into accommodation. So let's switch gears from musculoskeletal and talk about psychiatric impairment. Firefighters are at risk for major depressive disorder. They have a stressful job. They're at risk for post-traumatic stress disorder we've talked about before. They're at slightly higher risk for alcohol and substance use, abuse and dependence. And if they're on medication, there might be some impairment from the medications themselves. It's a tough job, and that's why most folks sort of get out at the 25-year mark with their pension, right? They're like police, they're like soldiers. We acknowledge that it's a tough job, and we acknowledge that we're very happy that they're doing it. So just to remind you, if you don't have a lot of psychiatry in your practice, major depressive disorder by the DSM-4, they have to have symptoms for 2 weeks. It's pretty well got to be every day. And the 2 symptoms they must have would be depressed mood, significantly depressed mood, more than you would normally have if you were just down, and a lack of interest or pleasure in things that you normally like to do. But then you have to have 3 out of the 7 other remaining symptoms. It might be a reduction in appetite, it might be poor sleeping, it might be poor concentration. And understand that the general population has a 15% lifetime risk. So you're going to run across it in your occupational medicine practice. So if they do have a psychiatric disorder, if they do have depression, what kind of impairment do we see? Well, we see affective impairment, mood impairment, the things that they like to do, and this may include their job, it doesn't get them off anymore. They don't like doing it. It's a struggle to do with some of these things that they used to enjoy. The cognitive impairment, there's really good literature that shows that with major depression, if it's moderate to severe, that there's going to be a reduction in memory, a reduction in concentration, a reduction in attention. And we're going to see in a moment that that's obviously all really important in firefighting. And there's associated physical, or what we call vegetative signs in depression. That would be loss of appetite and sleep disruption. So if you go into occupational medicine, you haven't done a lot of sort of psychiatry in your current practice, and bone up in your mental status examination. And what you're going to look for is, can they pay attention during the examination? Is there any psychomotor retardation? Remember, that's when it kind of looks like they're moving slower than usual. And then they may feel inside like I'm kind of like moving through molasses here. If you have some concerns about their attention and concentration, which is really important in firefighting, then there's some office screens that you can do that just take a minute. There's a mini mental status examinations, there's trail making tests A and B. So there's stuff that you can do in the office with pen and paper. And if they bomb those screens, they don't do well on them, then if you have the availability, you can send them for full neuropsychological testing with a psychologist. And collateral data is really important. Sometimes as an occupational physician, the referral is from the union or the employer, and they go, he's just not doing well in the workplace. And if they're going to say something like that, I'm asking for specific data. Well, what have you noticed? Well, he's fallen asleep on his desk, or he never used to make mistakes, he's making mistakes, or he used to be kind of a really jovial kind of guy, and he seems really sad and out. So I want to hear from the workplace or from the union, what have you guys seen? And then I can have a talk with the employee and say, well, you think you're doing okay, but, you know, this is what's being seen in the workplace. These guys aren't ratting you out. They're worried about you. Let's talk about this. And then sometimes that opens the door to, well, yes, I have been struggling somewhat. And then we move forward with the diagnosis and the treatment. So with psychiatric impairment, we can have impairment, so several regimes. There can be activities of daily living, which includes sleeping, which includes driving and transportation. There can be activities in social functioning, how you get along with people. Remember, in firefighting, it's a team job. You have to be able to communicate under really stressful circumstances with the other team members. And also, you have to be there to reassure and work with the public as well. So social functioning is really important to a firefighter. Task completion, this is sort of the synthesis of attention and concentration. If you're going to do a job, you know, can you see it through to the end or you get distraction? And adaptation is a really interesting concept for safety-sensitive work, because I might see somebody who looks really together in the office. You go, yeah, you know, I was depressed and I've stopped drinking and all that stuff, and I'm doing pretty good now, and they're friendly and they're smiling. But do they have the psychological reserve to go back into firefighting, which is one of the most stressful things? So it's possible they may decompensate once they get back into a firefighting situation, because they're good in their normal life, but they can't really step up to meet the job demands. And sometimes in those kind of tricky situations, I'm going to ask for a psychiatric review, because that's a pretty tough call to make. Or we can just send them back for non-safety sensitive work and see how they do. Do they show up? Do they do okay? Do they seem happy? So you can run sort of a little test case. So, I mean, you sort of get this intuitively, but there's very, very heavy psychological demands and active fire suppression. It's time sensitive. The building's burning down, right? Let's get on with the job here. There may be people inside. Complex problem solving. You have to sort of pick out the pertinent features of what's going on in a chaotic situation. Constant attention to detail. I have been in the smokehouse, and as part of my training as an occupational physician. So what that involves, the smokehouse gets to 300 degrees, and they generate smoke and they generate heat. And when you walk in, the smoke is about 3 feet here, and you have to crawl in the smoke, and it's pitch black. So they teach all sorts of techniques about how to go along the wall and not get lost. So what happens is every once in a while, you're in the smoke, you're in the dark, you pop up. It's like popping up above the water. You look around. This is 300 degrees now. You see what's up, and then you go back down into the smoke. So they're working in the dark. They have to listen. They have to look. They have to feel. They really have to pay attention to their environment so they can figure out where the fire is. Because you can't, in that particular environment, I could not actually see the fire until I got within about 2 or 3 feet of it, right? And then there was sort of a dull glow to the smoke. And you have to be able to communicate with the SCBA mask on in a noisy environment in smoke. So it's pretty demanding. So we've talked about firefighters, musculoskeletal pain and assessment. We've talked about firefighters and sort of some general concepts in psychiatry. So I thought for fun we'd do a case. And I thought, what the heck, I'm just going to give them the toughest case I can think. So we're going to have musculoskeletal problems, we're going to have psychiatric problems, we're going to have a hint of substance abuse, and just add a little spice, we're going to have a hint of malingering. Like, is this a real case or not? So welcome to my world, folks. Alrighty. So, and this would not be a standard return to work thing. This would probably be an IME. I don't want to scare you off too much here. Age 13, we have a history of this gentleman missing a lot of school. He's taken to see various specialists and so on. I can't figure out what's going on with him. Do lots of testing. Doesn't do well in school. Age 19, because of these sort of chronic abdominal complaints, he's given a diagnosis of chronic colitis. You see in the chart notes, whatever that means. At age 21, there's a really unusual situation. He's gravely ill. He's in the hospital, and then a couple of days later, just happens to be a home movie or video footage that he's swimming on the beach and having a great time with all his girlfriends. So what's that about? Age 21, he's been having low back pain since playing football, but now it's getting chronic. The complaints are going up, and he's starting to use a back brace. And then there's another fishy incident. He goes for a job pre-placement. Doug's told you a little bit about pre-placements. He fails that pre-placement examination. Then he goes back to exactly the same job, and he passes the pre-placement examination. And then the job that he has, he works in close quarters, and nobody notices that there's any problem. They think he's fine. And then, a year later, he's found to be permanently unfit for the job. So he's not fit, he's fit, there's no problems, and then he's permanently unfit. Kind of fishy, huh? So his back problems get bad enough that he has lumbar disc surgery. It's considered failed surgery because the pain doesn't go away. He requires a lot of narcotics afterwards. There's an incident where, after that, he's just doing a little bit of gardening. He says he's going to plant a tree. He puts the shovel in the ground, lifts up half a spade of dirt, and that throws his back out. So either he's really fragile or something funny going on. At age 29, he's diagnosed with Addison's disease, but it's well controlled with medication. It's not really an impairing problem. He starts to miss a lot of work around age 30. Age 34, jacks up the severity of the complaints and the frequency of complaints. It's unceasing low back pain now. Gets some trigger points for lumbar spasm. Another back surgery. Age 37, gets a lumbar fusion. Again, it's considered failed back surgery. There's a long sort of period of bed rest. There's some post-surgical depression. And then when he's examined by the physician documents 0 flexion, 0 extension. Well, that's kind of an anomaly. That's incongruent. We would know that, after single level fusion, you should get about, on average, about 45 degrees of motion with a standard deviation of about 12. So that's really outside the curve. That's an unusual finding. Age 42, documentation of exhaustion and trembling at work, so we're getting some feedback from the workplace. Things aren't going particularly well. Doesn't really want to work, falls asleep at a meeting, and there's concerns about his actual performance. At age 43, we're hearing, again, unbearable back pain at work. He's attending multiple specialists. Then it gets really interesting. We have documented methamphetamine use, anabolic steroid use. He's on all sorts of different medications for sleep, and he's reporting side effects of groggy and fatigue. And as you know from what firefighter talk, disrupted sleep is really important. Okay, so let's give, the guy's had 2 back surgeries, let's give that some impairment for the back. But let's move on to the cognitive stuff. There's been all sorts of complaints about that. So occupational physicians love scales. Now, I made one up. This is not an official scale at all right? So let's say 0 is this guy can't do any kind of work at all. 1 is he can do an entry-level job. He could be a meter and greeter at a Walmart, okay? 2, for moderate cognitive demands, this would be the kind of job where you have to go to school, to technical institute for a couple of years to do that kind of job. 3, difficult cognitive demands, maybe a professional, a physiotherapist, doctor, something like that. And 4, the hardest job. Now, when I was putting this together, I was all of a sudden appalled. As an occupational physician, I didn't actually know what the hardest job in the world was. So I Googled it. I got 2 answers. First was mum, and the second was President of the United States. Okay? So let's say President of the United States is the hardest job. So let's see what you guys think. So who thinks that this guy, from a cognitive perspective of his pain, can't do any kind of work at all? Oh, you guys are hardcore. Okay. Who thinks he can do entry-level job, be a meter and greeter at Walmart? Okay, good. We got a couple of people saying that. Who thinks that, he could do the kind of job where you have to go to school for a couple of years, a desk job kind of thing? Okay. Who thinks he could be doctor, lawyer? Okay. Who thinks he could be president of the United States? Okay. No political jokes came out. All right, good. All right, well, I've been a little bit rough on you. This is a celebrity case, so I've tricked you a little bit. So I'm going to give you some hints. This guy died in Dallas. This guy died in Dallas. This is JFK. This is JFK's medical history. And what I like about this case is it shows the power of motivation in going back to work. So he suffered a lot of pain, but he was, not everyone's going to be JFK, but this just demonstrates the power of motivation to go back to work. And as an occupational physician, when you have a motivated patient and you facilitate that kind of return to work, you get a lot of gratitude and respect for that. Okay, I'm going to leave it at that, Mark.
There you have it. Now's your chance to ask questions. Bob Bourgeois was talking about travel and executive physicals. We've seen the transition is young executives want to keep their personal health. I can be a diabetic, and that can stop their progression in the company. Physical exams for executives or employees going to other countries. They can be cleared here because of the limitations that we could have under ADA and that sort of thing. But that might not apply to Brazil. I had a guy that cleared cardiac return to work that cleared in Houston. And in Venezuela, they said, no way, we're not taking that guy because of the expense if something happens. So these are real live situations that you deal with in occupational environmental health. So questions, please. Ask your questions. What's concerning to you? What did we not cover that you would like to hear about? Yes, ma'am. Well, one of the question is heavy lifting. One of the things is that depends on the size of the company. We've had the push button that lifts 108 pounds, that sort of thing. So you have to really work with a company. Is it really necessary for them to lift that much? There's lift tables and that sort of thing. So as an occupational medicine physician, part of my responsibility is to address the health concerns of that patient. But the other is to help that company understand that they need to do something about this. So it's dealing with the patient and dealing with the company. You've got to, one of my slides was communication. You've got to have that communication with that company. Big companies, we always use IBM, but it can be any of the big companies. They've got the wherewithal to change the line if they can. Smaller companies, mom and pop operations, may not have that option. But the other thing is the fact that it's really, really important that there are standards that you have to follow, that you've seen the acronyms and that sort of thing, that you've really got to work within that and communicate with the company. But there's still jobs, where they're digging ditches 8 hours a day, they're lifting shingles, carrying shingles up a ladder. A bundle of shingles is 90 pounds. If you've ever seen these guys throw it up on their shoulder and run up the ladder, and they don't even touch the ladder. Now there's those trucks that have the boom that take it up on the roof. They still got to move it on an uneven surface. Occupational medicine is a lot of different work environments. One that I'm very intrigued by is performing arts. How many have gone to the theater? How many have gone to the ballet or the theater? Did you know that in a lot of times now the theater, the floor is canted? It's higher in the back than the front. And those performers, can you imagine what it does to the ankles? dancing and that multiple, as the angle of your of ankle changes where you are on the stage. Have you ever looked at the stage and saw that there's no railing on the front? There's an 8-foot drop to the orchestra pit. So the workplaces are fascinating and quite variable. Other questions? Yes, ma'am.
I have limited experience with that. Most of my job with firefighters is about return to work, but the guy sitting right in front of you might have a comment on that. Thank you. Sure.
My name's Tom Hales. I work for NIOSH in Cincinnati, Ohio, and actually we're just finishing up the largest study of firefighter cancer study done to date. There's about 13 what we call SMR studies addressing that issue, and they have mixed findings. Some show there's association, some show there's not. Individual states make up their own rules. There's no federal workers' comp determination whether it's covered or not. So individual states make that decision. And because there's no consistent finding between these studies, everybody sort of does their own thing. So some states have no compensation whatsoever, and some states accept all cases whether they're smokers or not. So that's the short answer. The good thing is we will have a study coming out, hopefully with results this summer, with we have 12,000 deaths in the cohort, of which 3,000 are cancer deaths, which is 6 times larger than the previous SMR study being done. So it's not a great answer to your question, and it varies.
Now, did he tell you that?
But one of the things that we've talked about, and it kind of permeates this, is the regulatory part. But this is exactly an epidemiology issue, an epidemiology question. And again, you've heard it from 2 of the presenters about occupational history. It's really important that when you're looking at a cancer case to get a complete occupational history. You know, I know lawyers that have gotten mesothelioma, okay? Lawyers don't get exposed to asbestos, but they weren't always lawyers. And I'll confess to you, I wasn't always a doctor. I was once a welder, okay? So get a good occupational history when you're seeing that individual. Great question, great response, thank you. I'll get to you next.
This is for Dr. Stuart Patterson. What is your experience with injuries and illnesses with female firefighters as compared to male firefighters?
Question is, what's my experience with female firefighters and injuries compared to male firefighters? They're a tough lot. I'd say the return to work factor is basically about the same. They're extremely fit. Most of the ones I know come from a marathon background and something like that, so they're really healthy folks. Moving into the pregnancy issue, we kind of leave it up to the female firefighter when they think the risks sort of outweighs the benefits. So they'll stay at work for a little bit, unless they're doing toxicological work, in which case they may choose to stay away from that. But at some point, no matter how fit and smart and strong they are, their balance point changes, and they really shouldn't be doing firefighting.
And their turnout gear doesn't fit.
And yeah, they don't really have pregnancy turnout gear. You're right. Any other questions?
What issues or experience do you have with workers who use computers chronically? You know, chronic migraines, neck, vision, anything, just so much of our workforce.
Well, the first thing to take a look at, is there any treatable medical condition that can be better controlled? Control with migraine is traditionally poor, so often we can move toward maximum medical improvement with the migraine, and maybe that'll take care of it. The next thing is just to take a look at the musculoskeletal components, and if it's a good employer, hopefully they'll have sort of somebody that does ergonomic assessments in there, so maybe we can take a look at, you know, does the chair have some armrests and so on, and improve that, so it'll reduce the tension in the trapezius and the neck muscles. In terms of the actual glare on the computer, my bias is that it's not that common that's actually causing a problem of itself. So my first step is I'm going to kind of look at other factors. If I have a relationship as an occupational physician with the employer, I'll go, is there anything going on in the back room? Are there grievances and so on? Is this about the fact that they don't like the job, or is this a legitimate medical complaint? If it's a legitimate medical complaint, first step I'll try is a little bit of psychological jiu-jitsu. I'll step out of it and I'll go, well, you and the boss, why don't you guys talk together and see if you can come up with a reasonable alternative? If they can't do that, then I'll have to take a medical stance on it. We can try some anti-glare screens and so on like that. If it really boils down to, in my opinion, it's unexplained and the person's still saying it really bothers them, I'm probably going to send them for ENT or neurological consult to see if there's any diagnoses that I've missed.
That brings up a real good point, though, and when, as a physician, somebody comes into your office and says, my shoulder hurts, so you write that down. But what do? You do a physical exam and you ask them some questions. In this situation, somebody comes in and says, my neck hurts, or, I feel bad when I'm using my computer. You need to do a history. You need to do a physical exam like you would normally do. So it's subjective and objective information that you're collecting. So, they'll come in and say, it's because of the chemical that I'm using. Does that fit? You look at the safety data sheet of that chemical and see how it matches up. So it's really important to get that history. Yes, sir. I think
it's a great example of what happens when you let engineers into medical school.
Yes, sir.
I'm actually a registered nurse, and I manage several occupational medicine clinics in Minnesota, and part of my job is recruiting physicians into our practice. And so my question is kind of twofold. Have you found that there's a certain background or a certain personality type of physician that seems to gravitate towards occupational medicine? And is there some aspect of occupational medicine that really seems to resonate with them to get them?
Well, we're exactly the same, so it's our personality.
I don't say musculoskeletal, even though I spent a lot of time in England. But, I think that one of the things that you'll see in the presenters, and this is kind of facetious and not, we're quite varied, but one of the things that you saw all the way through the presentations is practicality. Number one. Number two is it's an investigator. Doug talked about being an investigator. That's really, really important to evaluate and question and that sort of thing. Number three is the fact that your life is not, you're very comfortable not laying hands on like a surgeon. But to the point, who would ever think about taking care of a patient that's in the hospital and not going to the hospital and see that patient? You don't do that. You go in, you make rounds. You got to make rounds in the plants. You got to know what's going on in that plant. And as Bob was talking about, inviting the docs to come into the plant and see what's going on. Now, he said sanitized tour. Nah, he didn't really mean that. But, let them know what's going on, because what patients tell them is sometimes can be very different than what really goes on. And so I think that, so back to the point is practicality, communications. All the OG docs like to talk. Well, except me, I'm bashful. So those are the sorts of things. The other thing is the fact to accept team type work. If they come in like the MD stands for me, doctor, forget it. It's not going to work that well. Engineers are kind of like, they want everything cut and dry. I could tell you a joke about physicians and engineers and about numbered organs, but I won't. So, no, I work with a lot of engineers, and as far as team, that's really important. And you'll run into engineers in plants. I engineered that so that they can lift this, but they didn't think about the fact, the twisting that goes with that. Bob wants to say something.
That sanitized tour, since we had secret clearances, that had to do with national security. Now with sanitizing the work area. So.
Thank you for the clarification. Other questions or comments? Yes, sir.
Throughout the presentation, there was no mention concerning the collaboration between the occupational physician and the people that work in HSA, like industrial hygienists. Like in my own practice, oftentimes they call me an industrial hygienist, food doctor, inspection doctor. So I would have preferred a situation where, during the presentation, that collaboration, synergy between safety and environment with occupational physician is highlighted to throw more light on it to those people that want to be part of occupational medicine.
Absolutely. It goes with the team. But one of the things is, it was very curious, and it may have been the environment. I was part of occupational medicine in a corporation, and there was an occupational health group. And so we have a tabletop exercise about how to do emergency response. So I went over to being part of that. And they said, you're not occupational health, you're occupational medicine. We'll call you when they get hurt. Okay? No. So understand the lingo of the company, and before you take a contract with a company, understand about that company. What do they produce? What do they do? What's their philosophy? It's important, and it'll pay dividends and keep you out of a bind later. Yes, ma'am.
I'm really big on communication, and I get in those situations a lot. So sometimes if it's a simple point about work duty or so on, I might just write the physician and say, well, you didn't know about this, you didn't know about that. If it's a little more complex, then with the patient's permission, of course, I get the occupational health nurse to set up a phone call with the specialist, or often it's the family practitioner, right? My experience is, if I'm respectful and introduce myself and show, what my role is, when the physicians have the same pile of data in front of them, we tend to come to the same agreement. So the family practitioner or the neurologist may actually know something I don't know, and which I'll go, oh, okay. Or often I know something about the job, which is he can come back in light duties. Did you know that? That the neurologist didn't know, because the patient said, well, there are no light duties. And I'm saying, well, there are light duties, and we can get them back half-time for a week or two. So I find that communication is the key. If it doesn't work, then we just respectfully agree to disagree, and I put it to the referral source, which is usually the employer. I say, well, we have two doctors that disagree. You can go with one opinion or the other, or if you want, you can do an IME for a tiebreaker if this is a really, really important decision that you're willing to spend some money on. Yes, ma'am. You can do a functional capacity evaluation. Yeah, that would be sort of like doing an IME. You're getting sort of a third opinion and some new data.
Yeah, this week we just had a guy who thought he had a hernia, went to a family practice doc who said, yes, he's got a hernia. I checked him. I thought he just had an inguinal strain and I'd done surgery before. So we sent him to a surgeon for a third opinion, and the surgeon said, no, he doesn't feel the hernia at all. So anyway, he kind of explained to the guy that he does this every day, all day long, and it's not what he has, and it went away. Sometimes it does, sometimes it doesn't. The FCEs sometimes it depends on whether or not the employee really wants to come back as to whether or not the FCE will help a bunch in it, because sometimes it becomes adversarial. But again, talking to the specialist or the other doctor or the FP makes a big difference. And then the question about would docs gravitate and do well in here, most specialties, it depends on what you want to do some parts of it better than others, but we found in the clinical setting, especially if you have to run through a lot of folks in a day, some of the ER guys who see volume, who multitask a lot, may do a little better than some of the folks that have had a one patient an hour schedule, for 20 years. So if they've done, trauma centers or something like that, and they're used to seeing a whole bunch of folks and bouncing from bed to bed to bed, they seem to do real well. So we've had good success with those folks. Right.
One of the other things is to keep in mind, we've talked about the injured employee getting them back to work, but there's also that high-performance guy that wants to come back to work, and you've got to be, it's a two-way street. And you've got that executive that, oh, yeah, my stomach hurts sometimes, but yeah, I have dark stool, but don't worry about that. I'm okay. I can go. I need to go to this meeting in Europe, and yeah, I've got chest pain, but don't worry about it. That sort of thing. So you got to stay in the middle on these. You got to stay down the middle of the playing field, if you will. Okay, we got to stop. We can stay here and answer questions. I would like one or two of you that really feel like you can communicate to do a quick interview on the tape, because we're taping to get feedback from individuals so that we can use that to convince other people to get into occupational medicine and that sort of thing. So please, if you have any inclination to communicate, we need a couple of volunteers.
And the videographer's right outside the door, so when you walk out, smile.